The next presenter is M. Kinney and A. Mazzi from USA.
Well, thank you so much, everyone. We are very honored to be here and have a chance to present our applied research work to all of you.
Figuring out the microphone. There we go. Okay. A little bit of background of GBBN Architects. We are a company that has 3 offices in the United States and 1 in Beijing. And that's important because it gives us a cultural perspective that is broad. More importantly, though, I believe it's the types of projects that we choose to pursue. We don't do every piece of architecture, every project. We do projects that we feel are positive building blocks of community: healthcare, education, arts and culture, and housing. So what threads our research together and knits all this work together is this balance of understanding how people use that space in the behavioral socialization, and through our architectural craft, creating emotional connection through our work.
So just a little bit of background. I am an architect who is board certified in healthcare, and my research work is really centered on the why behind design, understanding those socio-cultural triggers that make people feel a certain way in a space or behave a certain way in a space. And Marcy, my colleague, is not involved in healthcare. She works in our arts and education division, and that really makes for a rich collaboration in what we're going to show you today. So we're going to start with some of the psychosocial research that I've been doing over the years and applying to our healthcare projects. And Marcy's going to tell you about her work with proxemics and social conditions in spaces. And then we're going to show you a collaboration between the two of us where we've analyzed one of our healthcare projects that we think is particularly relevant to this conference because it has flipped the paradigm of what healthcare is about. So we're going to analyze that project through the point of view of our research. So I wanted to start out just by saying, as we focus on wellness, on the concept of salutogenesis, it's really about removing stress. And stress is the root of all illness. Illness is very socially isolating. People don't want to identify as being sick because of all the negative associations and fears they have regarding what it means to be ill. So I kind of started saying, okay, how do we understand what is really going on in someone's head? What are the strategies? And I looked at some neuroscience studies, and 2 things really popped out at me. One was the concept of habituation, which is getting used to health problems, getting used to a compromised state of being. And the other was normalization, which is where you're basically rationalizing your problems, you're accepting a diminished quality of life because you're creating that new normal. You're changing the set point for yourself so that you can say that you're okay when you're really not. And it's one thing to think about that from a theoretical model, but it's also important to remember this is a real phenomenon that goes on. And in my own family, recently had this experience. Saturday, the day before I left to come here, my sister called me to tell me that my cousin John died of a heart attack at 43. This was a terrible tragedy. And when I talked to my aunt about it, she said he had put on a lot of weight. He'd recently flown to see them and was having trouble breathing. And she scolded him and told him to go to the doctor. He did not have a primary care physician. He was normalizing his health problems. After I hung up the phone with her and I thought about what she said to me, I realized he probably was experiencing congestive heart failure. But because he was normalizing this, he didn't seek treatment. He died in his home without seeing a doctor, having never even called an ambulance. So this is a very real problem with very deep and serious consequences. So when we look at why would someone avoid seeking treatment? Why would they feel that the treatment was worse than the illness? again, we go back to the idea of how our brains work and what our healthcare environments tell us about what it means to be sick and what it means to receive care. And at least in the US, I can say that we don't have a whole lot of greenfield hospitals. Many of our hospitals are older buildings that have had these additions kind of put on over time, kind of like tumors, and they're very complex. And when you're already dealing with the cognitive burden of your illness, it's very hard to navigate a complex environment to receive care. So it seems too hard to get it. There's also this sense that it's unpleasant to be in a clinical environment. And that creates a condition called confirmation bias, where we become prejudiced then against the environment. So then all we see when we walk into the hospital is the row of wheelchairs stacked in the corner or the medical devices festooning the walls. And we can't get past that to see the nicer finishes or the natural lights. So very quickly here, I wanted to run through from a project I'm just now undertaking where we're going to be consolidating some clinics into a new ambulatory care center, but I wanted to share with you observations from one of the existing clinics that I've taken on. And as I do this, I want you to tune into your own body and how you feel as you look at these spaces from arrival to entry to path to the exam room. So this is how people experience healthcare. And it's about emotions. So this is an example from a study that we did where we looked at emotion words in a before pre-design condition and an after design condition and how the design could move the needle. We wondered if this would apply outside of the US, so we worked with our Beijing office to devise a survey in Beijing, and we found that when we gave them a comparison of two different kinds of spaces, there was a clear preference for the spaces that had more warm, friendly, and salutogenic components. So that really leads us to believe that as architects, we have to kind of think like sociologists, and we have to apply things like relaxation, sense of coherence, prospect and refuge, and even, yes, the science of happiness, because when people feel joy getting well, they're going to want to do it more. So instead of just asking questions about programs and budgets, we need to be thinking more about how space feels and what the aspects of design, those building blocks, those environmental anchors are that are going to trigger the right emotional response.
So that's a perfect segue into several questions I've heard over the last couple of days, and that's how do we engage the users? How do we know our users? Well, one of the vantage points that we actually take is that we dive really deep into understanding who we're designing for. And we're not trying to put them in neat buckets. We don't think in generations. We don't think in age, actually. We think in life stages. The perfect example for me is think of a teenager who's dying from cancer. A teenager is trying to explore and discover, to find their identity and to start their path in life, yet they're being faced with issues that a typical 60 to 80-year-old person would be facing about the meaning of life and the purpose of life. That's a nuance that puts a person in a very precarious psychological state, and we have to be able to accommodate their vacillation between those moments. And there's many of those scenarios. So we think of our users, and we start to ask questions that help us really understand what activities are they trying to do in a space, what is the characterization of socialization that they want at any given time, and then be able to effectively accommodate that. Specific to waiting rooms, I love the presentation prior. This is many of the same similarities that we're finding, but we have to think about those nuances. Those nuances of how people engage both their personal and social realm while they're waiting. And specifically, and you'll get ready to see how we're applying this, we're doing this so that we can design intentfully and not simply by whatever our intuition's telling us. We want to be able to intuitively design and be able to measure socialization, and spaces where people can build community. So common space is at the root of this for us. This is understanding that common space is space where a user can self-select an area to occupy, and they can conduct any personal or social activity that they would so desire. So we focused our study on those public spaces. Waiting rooms are a perfect example of that. We're building on the science that Hall identified in the 60s of our comfort zones and the areas of distance where we feel comfortable having a stranger near us or someone that's familiar with us. So we took this data from observations of many common spaces, public parks, healthcare facilities, education, hospitality, pre-function spaces, and we started to measure and monitor the types of activities people did while they were socializing. We started to measure the type of space they occupied, and we started to measure how people started to group together to do these activities. And so that's how we started to organize thinking about how people use space. So using the proxemics measure, we have, we identified 4 types of activities. Quiet is very focused, and you'll see that within the personal and social proxemic zones, we're using a 3D modeling software to map the densities that we observed. So within the 4 to 12 foot radius of an activity, you'll see that the density of occupancy is quite sparse. And as we start to move through different spaces, casual space is an activity that typically is 2 to 3 people, much more flexible. It's a broader range of function. People are moving chairs. They have control over their environment, and therefore you'll start to see that the graphic dispersion starts to reach into further space that is affecting their feeling about being in that space to do an activity. The one that's very interesting to me, especially in the healthcare environment, is interactive space. This is a density pattern. If you look at the inner part of the circle, the density is very similar to casual activity, but there's a moment of positive distraction. That's where we were seeing like the images that we saw in Alan's presentation of seeing fish or a fireplace or even watching someone play ping pong. We're having conversation with a colleague or someone we know, but off in the distance, there's something else that captures our attention. So you'll see that the area that we design outside of that activity starts to grow and expand. And the last, just so that I can finish the comparison, is communal activities. And those are activities that are for 4 to 6 people, generally, because their personal zones start to overlap more, so they can have conversations and get to know each other better. The density is greater. These kinds of spaces, because of that, you really have to think about the space out to up to 25 feet away from an activity to design it well. So the last part is we actually, in these observations, were able to dissect 10 spatial characteristics of architectural interior design that started to help people make the emotional connection while doing that space or doing that activity. And so you'll see in the vertical axis things like acoustics, light, acuity, daylighting, views. I think I have to add smell to this list after the presentation yesterday. But then we started to prioritize which ones were most important to address in designing a successful space.
So now we're going to talk about the collaboration. The Sanya Fuwai facility really flips the paradigm on healthcare. It is a resort hotel that also is a cardiovascular hospital. It changes why you go to a hospital. It changes the experience. It changes the model with its focus on prevention, treatment, and rehabilitation. And we chose to study this project. It's just completing construction. So what we're showing you is our research setup, and we will then study this in a year from now post-occupancy. So what we've done here is we've taken the environmental descriptors that Marcy just explained and put them across the top, and then we chose 5 key communal spaces within the facility to rank which aspects of those spaces were important to understand and map further.
So let me just give you a bit of an orientation to the project. It is both a resort, as Angela said, and a place to receive medical treatment, but it is organized, very importantly, around two very large courtyards. The access to nature is absolutely essential to the design of this building, even so that the circulation through the building always goes around those courtyards. And the rest of the program is dispersed around the outer edge of that figure 8. What this does is, because each courtyard has a very different feel, one more natural, one more structured with pool settings and landscape settings, it allows for a multiplicity of functions, but also provides cognitive anchors for someone to find their way around that figure 8.
Yeah, so just to wrap it up, I thought we had 20 minutes. What we've done then is to take those spatial qualities, describe what are the primary needs of the patient in each of those spaces, what is going on in terms of activities, and then to apply, using our 4 psychosocial theories of prospect and refuge, sense of coherence, relaxation response, and happiness, how well, on a scale of 1 to 5, each of the spaces performed. So you can see the proxemic map, which is not looking at what's actually happening in the space. It's looking at what the design is fostering in terms of behavior. And then we're looking at what is the true desired behavior. And so as we go through these spaces, you can see that for the most part, we are scoring 4s and 5s because this facility was very intentionally designed to foster that kind of behavior. But one area that we did want to point out was the waiting rooms, where they are kind of, although you are facing an open courtyard, because you don't have any back to the space, we felt there was a poor sense of prospect and refuge there. But essentially what we've tried to do is just see how looking at a different model for doing healthcare can create a different effect for people using the space. So how can this apply to other projects? We feel that connection to nature is a very strong environmental anchor. It helps with wayfinding as well as providing access to natural light. We feel that incorporation of elements that visually reference familiar positive environments can help to create positive associations, and providing choice in the environment creates a more empowered patient who has a greater sense of happiness and self-efficacy. And finally, reinforcing through the design a level of socialization appropriate to the activity within the environment is important, and we can understand that better through the use of proxemics. Thank you.